everyone, and welcome to this standalone webinar from the Hand Education Committee from AO North America. Today's session is on tendon transfers. My name's Cham Udgal. I have the relatively easy task of moderating some very seasoned veterans and superb faculty, namely Chuck Cassidy from Tufts, Shrikant Chinchalkar from Ontario, and Marco Rizzo from Mayo Clinic. All the disclosures are up here and all the conflicts have been resolved prior to this webinar. The learning objectives of this webinar are quite simple. We will analyze nerve injuries and how they create deficits. We will analyze tendon injuries and how those create deficits. We will also list the ways to address these by tendon transfers, by understanding the mechanics, the basics, and the rehabilitation to maximize outcomes. Our agenda is a little different from the one shown here. I'll be talking about the basics initially, followed by Chuck Cassidy doing radial nerve injuries. Marco will take on median nerve, followed by Chuck doing ulnar nerve. And then finally, I will do the tendon ruptures, and Shrikant will round it out with rehabilitation. If time permits, we will have case-based discussion at the end. The Zoom etiquette, as usual, all your mics and cameras have been turned off, and you are most encouraged to ask us questions in the Q&A and not in the chat box. So with that being said, I will kick off the session with the basics. And let's see, there we go. So here's a 52-year-old male who came to see me after his glove got caught on a drill on an oil rig, and it forced his wrist into significant degree of flexion when he was least expecting it. He was seen at a local clinic, and he was told that he had a wrist sprain, and the lump on the back of his hand was attributed to being a wrist sprain. However, when he came to see me about 2.5 to 3 weeks down the line, he had no digital extension. So a diagnosis of digital extensor rupture was made, and when we opened it dorsally, we found this mass. I gently tugged on the mass, and his extensor tendons came into the wound. So that is not a situation that you can address given the level of the injury. So let's see what we can do to injuries such as this and nerve injuries. So what is a tendon transfer? We reroute a functioning muscle tendon unit from its anatomic insertion to a new insertion so that it may perform a function for which the good Lord, in all her wisdom, never originally designed it. The principles of tendon transfer have not changed in over 100 years. Mayer, who worked in Professor Bizelski's lab, published these principles over 100 years ago, and those remain true even today. In fact, Sterling Bonnell, the father of modern American hand surgery, seen up here on the top, emphasized these as well as atraumatic technique, along with Joe Boyce. So when should one do tendon transfers? Well, when neurologic recovery has plateaued and the tissues are in equilibrium, you don't want to operate through fresh scar. You want to have a healthy soft tissue bed. The skeleton must be stable and the joint should be mobile. No matter how good your tendon transfer, if the skeleton is not stable and the joints are stiff, this is not going to work. If the bed is too scarred, prepare the path with a hunter rod. Now, this is one of my favorite slides because I think it's really critical. The pre-op milieu of the patient. You must align your goals to the patient's expectations. Otherwise, either or both will be disappointed. You want to wait for the neurologic deformity deficit to have evolved completely. You have to take into account social and emotional factors. Is the patient, if the patient's tetraplegic, how are they dealing with the injury? If they had a bad, devastating nerve injury in the upper limb, how are they dealing with it? What are their functional requirements? What is their family situation? Can someone bring them to their visits? Can someone bring them to their rehab? How are they going to get by? You want to ask them to keep a diary of what is needed, not what can be done, and make sure you match those two. If they have any visual deficits, that's going to be a problem because sometimes mirror therapy is a very useful part of rehabilitation. In stroke and TBI, receptive and expressive aphasia can be a problem because if they have receptive aphasia, they can't follow instructions. And if they have expressive aphasia, they can't tell you what they're feeling. Finally, the hand should ideally be sensate. When I look at indications for tendon transfer, I look at it like this reverse traffic sign. where the green zone is where you replace tendons which are ruptured or avulsed. And it is an alternate to tendon repair. And these are some of the easiest injuries to take care of. In the amber zone, you replace a paralyzed muscle, and you restore balance to a deformed hand, because restoration of balance is one of the prime goals of tendon transfers. And finally, the red zone, where you're dealing with spastic disorders or spinal cord injuries. My personal philosophy is simple. You follow well-established guidelines and follow well-established protocols. But you must customize to the needs of each patient. And for that, you've got to listen. Ask them what they want and see if that's realistic. You look at what their vocational needs are, look at what their avocational needs are, have them keep a diary, like I said before. Be prepared to think outside the box and be bold, but don't burn any bridges. Now, you have to understand that a lot of these patients come to you with a lot of hope. Be positive, give them hope. Don't be a downer, but at the same time, you've got to be realistic. How do I select donors? Well, this is a tried and trusted method. Find out what works and the MRC grade, because as we know, tendon transfers will lose a grade of power after transfer. So this should at least be grade 4. What's available and what's needed? Mix and match the two based on function, amplitude, direction, and integrity. Just because you can do tendon transfers doesn't mean you have to do tendon transfers. Sometimes fusion is an alternative, which must be considered. The ideal donor should be functional and expendable, and like I said, should have adequate strength and excursion or amplitude. You want one tendon to do one function, not multiple functions. It should be easy to retrain, but Srikanth will get into that. Ideally, you want it to be synergistic. So what do I mean by one tendon, one function? This is a principle that Brand emphasized to us many years ago, where, and you also want to make it pull in a straight line as much as possible. But don't forget the angle of pination. The angle of pination is where the muscle fibers blend into the raphe, which leads to the tendon. If the muscle fiber and the angle of pination is very high, then yes, they will generate a lot of force, but at the cost of excursion. So here's the patient who had ruptured his extensors. We transferred his FCR to the EDC around the radius. There's his original line of pull of the FCR, and our angle of approach is just about 30 degrees, which is as close to straight as possible. This is an injury which has been described in gymnasts when they're dismounting off a high bar and they forget to let go. And here he is at about 10 weeks when he went back to work on his oil rig. Now, is this outcome something spectacular, or did we pay attention to our tension? Did we set it correctly? And what do we mean by that? Let's go back to Physiology 101. Here's the sarcomere with your actin and myosin filaments, and in the resting state, there's a good amount of overlap of the actin and myosin filaments, allowing them to generate force. If you elongate the sarcomere, the degree of overlap becomes much less, and that's not good, because we know that the resting length is the position from which the muscle generates its greatest force, which relies on fiber length, and in turn relies on sarcomere length. Now, multiple studies have shown that the sarcomere length in most human forearm muscles to generate optimal force varies between 2.4 and 2.8 micrometers. Now, is that the only thing that we take into account? Well, Richard Smith told us that you have to consider the viscoelastic force, which is the combined resistance to stretch by muscle, fascia, and connective tissue. And if you see here on the right, you'll see that in a stretched muscle, the viscoelastic force increases, but the force of contraction actually decreases. So stretching a muscle and making it long and tight doesn't really help you. That's one reason why. The second reason why is the Blix curve, where it describes the relationship between the resting length of a muscle fiber and its ability to generate tension in response to nerve stimulation. These two red lines show you a small plateau, and which is the amount where you have wiggle room. What do I mean by that? That's where you can increase the tension on your transfer and make it just a teeny bit tight. Otherwise, what happens is you take the tendon transfer and take it into the tension from an active muscle tendon transfer, you take it into a tenodesis. What do I mean? If we are traditionally taught, make it as tight as possible, but that goes against the Blix curve because it sets the length of the sarcomere longer into the passive part of the Blix curve, making it mechanically inefficient. Now, is this just basic science, or has this been tested? Well, Jan Frieden and Rich Lieber looked at this, and what they found was, if you in fact increase the length or the tension on a muscle tendon unit, you actually lose sarcomeres, making it an inverse relationship, converting your active muscle tendon transfer into a passive tenodesis. Therefore, setting your natural length is optimal. And let's look at this. Here's an example with the wrist and extension. You can get MP flexion of the fingers, and you can get the thumb to oppose to the index as well as to the pinky. And then when you bring the wrist into neutral, you can see how the fingers are extending by tenodesis, and you can see how the thumb is extending. So the thumb sits in just about 10 degrees of flexion each. Make these a little tighter than loose. And, can I have a freer, please? So in addition to setting tension, you have to also maximize the effective amplitude. Now, what do I mean by that? Effective amplitude is what we get in the operating room. Now, total amplitude is the combination of passive excursion and active flexion. Now, always want to transfer a tendon with a longer fiber length to one with a shorter fiber length, as shown here. If you take the brachioradialis, its excursion with just a minimal distal release is only about 5 millimeters, and that is because it has such dense connections to the forearm fascia. But the minute you release those, its excursion becomes 25 to 30 millimeters, making it far more effective. In addition, in a muscle tendon unit which crosses two joints, it is really critical in tensioning when you position the proximal joint also into flexion. Now here's someone with Silver syndrome, and you can see the right thumb is unable to flex like the left. So in that patient, it was a simple transfer using the brachioradialis to FPL, using the principles that I just defined, and giving a very effective FPL function. So we know how to set tension. We know how to take into account proximal joints. How do we repair them? That's the last part of the basics. The repair must be robust to allow early rehab, but should minimize the repair bulk. Traditional teaching, use the Pulvertaft weave. 4 weaves orthogonal placed to each other. Problem, big bulk. It has withstood the test of time, but is there an alternative? Brown and colleague came up with a tenorrhaphy where you do one pass and then do a side-to-side repair. And the thinking was that it was as strong and perhaps less bulky. How do you test that theory? Well, we took it to the lab, and what we found was when we compared the Pulvertaft to the side-to-side, that the side-to-side technique showed superior biomechanical properties compared to the Pulvertaft, and that bulk was actually similar. So now we know how to repair these tendons also, and that's where I stop, and we go on to transferring tendons. Chuckles, all yours.
Thanks, Chai. That was terrific. All right, so we'll start with the, I would say, the most straightforward set of transfers in the upper extremity, and that's radial nerve transfers. There's been a lot of talk recently about nerve transfers, and that's not really the topic of this evening's discussion, but it's an interesting one to think about. Why use tendon transfer over nerve transfer with respect to radial nerve palsy? Well, first of all, radial nerve transfers are the most reliable sets of tendon transfers that we have. And the second is that the nerve transfers sacrifice potential motors, like, for example, the FCR, FDS, in the hopes of making things normal. So in other words, under the best of circumstances, a nerve transfer could provide a better outcome than tendon transfers, but it is the riskiest. So what are the goals of transfer for radial nerve palsy? Number one, strong wrist extension for grip. If you've ever seen a patient with radial nerve palsy, give them a grip meter. When they attempt to grip with the dynamometer, their wrist collapses into flexion. So in order to have good grip, you need to have a stable wrist. So strong wrist extension, very important. Full thumb and digital extension for release, plus or minus independent digital and thumb extension. As Chai mentioned, strength is an important consideration. And it's important to remember that we lose a grade of strength after the transfer. So if we use the relative value of wrist extensor as 1, the pronator teres is really an ideal transfer because it has a potential force of 1.5. So stronger than the native wrist extensor. On the other hand, digital and thumb extension does not. That's more positional. And you can see here that the relative strength is much less than the wrist extensor strength. The next is amplitude or excursion. So it's important to remember the 3-5-7 rule. So the wrist flexors and extensors have about 3 centimeters of excursion, the digital extensors 5, and the finger flexors 7. So if we look, the FCU and FCR common transfers for digital extension have only 3 to 4, whereas the digital extensors themselves have 5 to 6. And the FDS has more even, is 6.5. So there are groups of transfers that are well described, and the name of the transfer, not the eponym, but the name of the transfer is with respect to the transfer to the digital extensors. They share in common pronator teres to wrist extensor, all 3 of the most common. My preference is pronator teres to ECRB, so it centralizes the transfer. For digital extension, the FCR to the EDC, and for thumb extension and abduction, the palmaris longus to the rerouted EPL. Why? The FCR is much easier to mobilize than the FCU. If any of you have done an LRTI, you know that it's pretty easy to retrieve the FCR. The FCU has connections all along the forearm. The donor morbidity is negligible. The FCU has been identified as important in the dart thrower's motion, which is a critical motion of the wrist in daily activity. And for me, the line of pull through the interosseous membrane, so Chai had mentioned around the radius, which was the original description, but the line of pull through the interosseous membrane is straight and does not require transecting the EDC tendons. So pronator teres to ECRB, the pronator teres should be harvested with a strip of periosteum because the tendon itself is quite short. And so this will help to extend the length of the transfer to suture into, and there's no clinical loss of pronation from this transfer. And then the FCR to EDC, as you can see here, as Chai illustrated in the last talk around the radius. Remember that the wrist motors have 3 centimeters of excursion, whereas the digital extensors normally have 5. So we're relying on tenodesis of the wrist to augment or step up the extension of the digits. With that in mind, the FDS transfer may be preferable in 3 circumstances. So for example, if you had a wrist fusion and you did an FCR transfer, you wouldn't miss the FCR, obviously, because your wrist is fused, but you would have difficulty. Either it would be tight and you'd have trouble making a composite fist, or you'd have an extensor lag because it doesn't give you enough total excursion. You need 5, you only get 3 unless you have the wrist. Second is if you need simultaneous wrist and digital extension. For example, I had a patient who was an electrician and he needed to work in the ceilings with his wrist and digits extended simultaneously. And that's very difficult to accomplish with a wrist motor for digital extension. And then third, the lack of a palmaris longus and need for independent thumb extension. So how tight is just right? So Chai talked about the sarcomere length and it was compelling. And I would say a couple of things. One is that physics is smarter than we are, and some accommodation does occur. And so as you heard in his video, he said, a little tighter is better than looser. And so it's very difficult to know exactly how tight to make it, but I would say a little tighter is better than looser because there will be some accommodation as the tendon finds its shortest path. So it's going to loosen a little bit. And also there'll be some softening of the tendon at the suture site, which will result in a little bit of relative lengthening. So what I like to do is I transfer the pronator teres first. And so I do it so that the wrist is just resting in about 25 or 30 degrees against gravity when I let go, but I can still passively flex it. And so like Chai demonstrated, so then I'll transfer into the digital extensors and then make sure that they'll extend fully with the wrist held in neutral. And then like Chai did, when you bring the wrist into extension, then you can flex the fingers fully and bring the thumb all the way over. Just the general rule of thumb. So for me, the FCR through the interosseous membrane, which was the description for the FDS, so I've just taken that already described technique, has the most direct line of pull, and you don't have to transect the EDC where there are a lot of loose ends. And tenodesis of the EDC ends proximal and distal to the FCR attachment point with the adjacent suture before attaching the FCR, it really simplifies the transfer, and I'll show you. And then add the EPL last if you're using the FCR as a motor. That means if you don't have a palmaris longus, and you're just going to suture the EPL into the mass of digital extensors, do that last. This is an example. This is a cadaver. And I'll show you the proposed incision. So one on the dorsum for the digital transfer and to harvest the EPL and reroute it. My original incision was proximal in the forearm, like for an FDS, but I don't do that anymore. A couple of little incisions for the palmaris and FCR, and then a radial incision as you see here. So this is a radial mid-forearm incision to harvest the palmaris longus tendon. So here we're in the brachioradialis ECRL area, and we're going to retract the brachioradialis dorsally to expose the pronator teres. So if you pronate the pronator teres, you can trace it to the distal insertion of the tendon, and it has a fairly broad insertion, but overall a short tendon length. So harvest that with a strip of periosteum to gain as much length as you can. And then there are some fascial connections proximally in the forearm, just as with the brachioradialis. And so you need to release those to get the maximum excursion, as you see here. And then this is probably the most important slide for me when talking about tendon transfers. When I first started doing transfers, I would transfer it into the tendon as it was resting in the forearm, and I'd pull it and I'd suture it in where I thought it was the right length, and the wrist would just collapse. And then I'd pull it harder and suture it in, and the wrist would just collapse. And I realized there's too much slack on the recipient. And so this is what I call a yoke stitch. So you place a yoke stitch proximal to the intended insertion point of the transfer, and then get rid of all of the slack with that yoke stitch. So now the tendon's under tension, and so it's not going to accommodate, hopefully, much. And then you can either do a Pulvertaft weave, as I'm showing here, or a single pass and then side to side, as Chai demonstrated. So there it is, pass it through, and then suture it, and then pass it again at a 90-degree angle. And you can see what a relatively small stump there is. And if you ever get caught where you don't feel like you have enough length, you can take a portion of one of the wrist extensor tendons and bridge it. And so suture on either side to augment the repair. It's not in a flexor tendon sheath or anything, so it's not going to get hung up, and it will help to strengthen the repair. Then next, we make an incision proximal to the extensor retinaculum, and you can open the extensor retinaculum as well if you'd like. I open the proximal portion of the extensor retinaculum in the third and fourth compartments. And then mobilize the EPL and then transect it. So we're taking it out of the third compartment. As you know, if you pull on the EPL, as you see there, it retropulses the thumb and adducts it, which is not a functional position. What we want is really more of a radial abductor, right, than the EPL. So it's really sort of replicating the first compartment to some degree. So you transect it proximally, and we'll retrieve it later distally, and then retract the extensor tendons, and then you're looking at the interosseous membrane, as you see here. And then we make a window, and you want to make a big enough window so that the transfer doesn't get hung up in there, and it's just proximal to the pronator quadratus. So make an opening in the interosseous membrane and resect some of the interosseous membrane. Then we'll transect the FCR at the wrist, and it's easy to retrieve it in the forearm through that same incision that we used for the pronator teres to ECRB. You can see I have a nice length of tendon there. And then there's the opening in the interosseous membrane, and take a Kelly, pass it from dorsal to volar, grab the tendon, and the FCR now is into the dorsal incision, as you see there. Next step is to set the cascade. So the cascade, meaning that in the resting position of a hand, the index finger is relatively more extended than the small finger, as you see. And then what we'll do is we'll tenodese the digital extensors. So we don't transect them, but that suture them to one another, proximal and distal to the anticipated FCR attachment point. The distal one is critical. As you see, when I'm pulling up on that stitch, it's bringing the MP joints into relative extension where I'd like to see it. Okay, so it's not full extension there, but it's relative extension, the index relative to the middle, ring and small. And then when you do the transfer of your FCR, as long as you're in between the uprights, between the two stitches that you've placed, Again, I have a yoke stitch proximally when I'm suturing. So I'm just going to weave it through. You don't have to do a Pulvertaft into the individual tendons. As you see, the FCR is much bigger than the individual EDC tendons. You can weave it back and forth in between like that. And as long as you're in between the two, you won't adversely impact the cascade that you've already set. And then finally, thumb extension and abduction. As I mentioned, we take the EPL out of the third compartment and then retrieve it through an incision volar radial. And we'll suture that to the palmaris longus. So as you can see here, now it is really a radial abductor. And here I've done a Pulvertaft weave. The palmaris is absent in 10 to 20% of patients, as you know. So obviously before the surgery, you want to check to make sure that they have a palmaris longus. If not, have your plan B. So what's plan B? One option is the FDS to the EPL. You could do it to the EPL and the EIP if you'd like. So it has great excursion. It's probably a little stronger than necessary. Or you can just suture the EPL. Again, I would free it up. And ideally, you want to have that line of pulse so it's really more abducting, but it's going to tend to retropulse a little bit if you leave it on the dorsum of the wrist like that. But after you've already done your transfer, then you suture the thumb into it so that the digits all open and close together like that. Postoperatively, I use an above elbow cast because of the pronator teres crosses the elbow, but you could probably get away with a below elbow cast with the forearm pronated, the wrist in 45 degrees of extension. So there's no stress on the wrist extensor transfer. And the MP joints in a little bit of flexion. I don't like to have them in full extension. So if you extended the wrist, you don't have to worry so much. Let the MP joints flex a little bit. And then you can have them do interphalangeal motion with the MPs blocked. And then the thumb fully extended and abducted for 4 weeks, and then a short arm version for another 2 weeks, and then a part-time nighttime splint for another month. And it's really to keep the wrist extended and the thumb abducted and the MP joints extended. And so that I would say is probably a little bit conservative. You may be able to get away with earlier motion than that, but for me, it's like baking a cake and it's in the oven and my results are good. So I'm reluctant to change. The pitfalls, excessive radial deviation, and that was more common with the FCU transfer. So you're removing a strong ulnar deviator and flexor, or if you transfer it into the ECRL, that will pull the wrist into radial deviation. Overcorrection will limit the ability to extend the digits because you need to have tenodesis, right, for release. Or if you overcorrect the digits, it'll limit your MP flexion. So you'll lack some composite flexion. If you undercorrect, it's important to differentiate too long from adherence or inappropriate contraction. So we talked a little bit about synergistic transfers. So a wrist extensor to a finger flexor or a wrist flexor to a finger extensor are synergistic. And FDS, making a finger flexor become a finger extensor, is not intuitive. And we may hear a little bit more about that later, but training preoperatively may be a good thing. I have seen a couple of patients who've been unable to fire the FDS appropriately after a transfer using the FDS to digital extension. It's generally considered a great transfer. There's very little outcome data, to be honest with you. So wrist extension strength is good. Digital extension strength is not great, but it doesn't need to be because it's really positional. And grip ends up being about 50% of normal. Nevertheless, it's generally felt to be the most reliable set of transfers. Attention to proper tensioning is critical. I would say you got to make sure that the wrist transfer is not resting in flexion because it's never going to extend enough afterwards. With few exceptions, the FCR to the EDC is the best. You could do it either through the interosseous membrane or around the radius. And the FDS is better suited for stiff or fused wrists, and the absence of palmaris longus requires some decision-making. Thank you.
Chuck, that was wonderful. While Marco's pulling up his slides for the median nerve, can you, for the sake of the audience, outline what anatomic landmarks you use so you can put your incision for the pronator exactly where you want it? I mean, how do you decide that? Because it's not, you know, everyone's forearm is not the same length. So do you use
Right, right.
centimeters or do you use rule of thirds, or what do you do?
Yeah, it's pretty much, it's more distal actually than you might think. And I think for those of us who've taken care of stroke or CP patients, their pronator teres is often tight, and we do lengthenings, and it's very easy in those patients to palpate the pronator teres and where it's headed, and it's really it's more distal, and it's at about where the brachioradialis becomes tendinous. So it's down in this area. So if you feel the brachioradialis where it's transitioning from muscle to tendon, it's at about that level. I think the error is probably is to make it too proximal.
Yeah.
Yeah.
Okay, great. Thank you.
Thanks.
All right, Marco.
Thanks, Jai. And nice job, Chuck. Thanks for sharing your wisdom again. It's really grateful. I'm really grateful to see it. I'll try to be as dynamic. I doubt that I will be. My charge is to talk a little bit about median nerve, and I have no relevant conflicts. I think as we're going along with the tendon transfers, the radial nerve is sort of the king of tendon transfers in the sense that of predictable outcomes. The median nerve is a little bit less predictable, and I think the ulnar nerve's arguably the most challenging. So these are my learning objectives, and let's start with the anatomy real quickly. We'll talk about the anatomy of the median nerve coming off the cervical 6th through 8th vertebrae, branches. And typically as we go down towards the elbow, the first branches to the pronator teres, subsequent branches 2 through 5 are typically the FCR and palmaris and flexor sublimis. Further down, the IN branches off and provides us function for the FPL and FDP, the index, and the pronator quadratus. And finally, down into the hand, we got the ever important thenars and lumbricals 2 and 3. And we're talking about different types of problems for these nerve. Oftentimes, we'll see low median nerve function in really severe carpal tunnel and compressive neuropathies, but there are notable traumas that can occur that result in median nerve function loss, supracondylar fractures, both bone forearm fractures, crush injuries, partial complete amputations, distal radius fractures, as well as compressive neuropathies. And like, Chuck showed really quite nicely, you got to sort of understand what's in, what's out, and what's needed. And following this simple protocol is helpful for any tendon transfer, as Chai also alluded to. So in this case, any non-median nerve muscle, as shown in the left-hand column, is likely in. What's out, again, thumb opposition, finger flexion, and thumb flexion. So those are the main things that are out in median nerve palsies. In terms of timing, it's important to think about this as well. You want to make sure that any neurologic recovery has plateaued. The tissues have achieved an equilibrium. That is to say that the inflammatory process has sort of worked itself out and edema has subsided to minimize further scarring or tethering. That there's a stable and a healthy soft tissue bed, that the skeleton, of course, is stable, and that the joints are supple. This applies to all tendon transfers in terms of timing. Dr. Brand's work has been cited a couple times here, and it's been hugely important in our understanding of tendon transfers and defining the capability of the donor muscle, excursion potential, things to consider, force potential, and how much does the donor really match up with the lost muscle function. So let's get into it. Let's talk about probably the biggest thing and the most talked about tendon transfer for the thumb and median nerve deficit hands is opposition. And restoration of opposition is needed in more than 50% of complete median nerve lesions. So it's important to remember that. And you got to think of it in terms of high and low. Like this case example of a camus transfer we did, which is typically appropriate for folks who have a low median nerve palsy. But in a high median nerve palsy, you don't have these options. You have to think about different options, such as a EIP transfer. So these are the kinds of things to consider. when localizing the high versus low median nerve. And we'll get into that a little bit more later. A couple of things to remember: tenodesis effect can really increase your tendon excursion by 2 to 3 centimeters. Chai talked about Mayer's rules already. Remember those. Those are very important in helping you optimize your choice of transfer and success. Unlike flexor to extensor transfers, which a lot of us agree that you want to be a little on the tighter side, much like what Chuck showed on that transfer from the pronator to the ECRB. Extensor to flexor transfers tend to be a little bit less forgiving of overtensioning, and overtensioning can result in flexion contracture of the digits in those cases. So we want to do our inventory. We want to see what's available for opposition. Different transfers named after different giants of hand surgery, as you can see. And you also want to consider associated nerve injuries. So many patients will have a combined median and ulnar nerve, and you have to weigh that into your deliberation about, you know, what's the optimal transfer for those patients. Remember, of course, as Chai suggested, you don't want to have, you want to at least have an M4 muscle strength. So getting an EMG in many of these patients with combined injuries is critical in helping you understand how, to what degree the muscle is in addition to your physical exam. What are we lacking when we're considering an opponent's transfer? We're lacking muscle bulk, we're lacking muscle force, and we're lacking excursion or opposition in terms of circumduction. And think about the desired action, the insertion of the tendon, and the choice of tendon muscle. And this is important to consider in these patients. Here's that article again from Brand that talked about defining some of the mean muscle volumes, the mean fiber lengths, cross-sectional areas, and tension fraction of common muscles that we would use for transfer. And there have been defined muscle mass tension percentages in the thenar muscles, and that 3.5 average mean fiber length and 3.8% cross-sectional area are fundamental numbers to keep in mind when you're thinking about the ideal transfer. So if we look at that compared to our potential donor options or tendons like ECU, ECRL, FDS to the long and ring, and EIP, you can see, for example, EIP has a very good fiber length, but not so good tension and mass volume compared to the thenar muscles. And weighing these is important in determining the best choice for transfer. The Huber transfer, I think, is good for folks with a hypoplastic thumb. It's also a good option for patients who have a high median nerve injury. It matches the area and excursion pretty well, but lacks flexor sumbal dysfunction and excursion in that way. When thinking beyond the principles of the cross-sectional area and excursion, think about the direction of action of the thumb and how pulleys can impact that. So where you locate your pulley is really important, and it does impact the amount of excursion and direction of action you're going to get. So when we look at pulley locations, we look at the pisiform palmaris longus, the FCU sling can be used, carpal tunnel distally in the ulnar border of the forearm, much like what you would do with an EIP transfer. Using this to help you, of course, will give you optimal opposition. When you look at an FDS transfer, it actually has a very good tension fraction in terms of comparison to the thenar muscles. It matches the muscle area pretty well. The downside with this is it doesn't restore thenar bulk very well. I like the EIP transfer. I know it's not a favor of everybody's, but I like it. Second to the FDS, this is a transfer that I'm a big fan of, and I like it for a couple of reasons. It's a good choice in high median nerve injuries as well as combined median and ulnar nerve injuries. And it also provides good balance without loss of function. There are some challenges with it. Sometimes it's a little short and tight, and it's okay to supplement it with a graft, in my opinion. But with a good technique, you can get good excursion of the tendon and maximize and maximize its uses without the graft as well. Make sure you get as far distal as you can here to get as much length as you can, because you're going to need it. Postoperatively, for these opponentsplasties, I typically put them in a thumb spica cast for about 4 weeks, and I'm pretty liberal with immobilization, as the thumb base is usually pretty forgiving. But you can vary it based on how happy you are with your repair and your reconstruction. Gradually graduate to a removable splint and begin motion and strengthening at 3 months. Remember a couple things as well. Dr. Brand's one tendon, one function rule is important. Try to avoid getting overly ambitious and trying to do 2 functions with 1 tendon transfer. For example, don't try to achieve opposition as well as thumb extension with a single transfer. Where do we insert these tendons for opposition? Well, I tend to prefer Littler's recommendation on where to suture at the APB, but you can also utilize Brand's, Royden's, and Royal Thompson, which all in various variations on a theme basically identify locations where you can do the opponentsplasties. Let's quickly go to high median nerve injuries. So what we're lacking in high median nerve injuries is finger flexion and thumb flexion, as well as opposition. And basically, I take an inventory of what's available. The EIP, again, as I mentioned earlier, is a good choice. You can do an EPL to reroute for opposition, or a wrist extensor for opposition. What about for finger flexion? Well, you can do an ECRL or ECU transfer, an FCU transfer as well. The FTP to the ring, a little, and a side-to-side repair, I think is a good choice for most of my patients and my preferred option. And I think using the BR to help with FPL is a good choice as well. So a good example is BR to FPL, EIP for opposition, and FTP side-to-side, long in index to ring, or ECRB or L to FTP, index and long. Here's a case example of that exact transfer, and you can see the repairs. So in summary, opposition is usually the fundamental mainstay of many of these median nerve transfers. Again, for my practice, I think for the thumbnail rotation to get the best opposition, I prefer flexor superficialis, but also the indicis proprius transfer. I think the EIP or FDS matches the muscle area tension, fiber length, particularly the FDS matches the muscle area tension, matches the fiber length, and allows good abduction and rotation, and the moment arm gives optimal strength for pinch and grasp. For high median nerve palsies, I prefer the EIP for opposition and the side-to-side FTP. And if I can't do that, then the ECRL. And for the FPL, I'll do the BR to FPL transfer. Thank you.
That was wonderful, Marco. Thank you very much. I did want to ask you a little technical tip that you may have. When you take that EIP around the ulnar border, right?
Yeah.
Do you worry about a dorsal cutaneous branch of the ulnar nerve? And do you do anything special about it?
Certainly we do. And you want to be sure that you've got a tunnel that you can clearly identify and protect that branch, because there's times when you're really, either focused on worrying about compressing it versus so you want to make sure that you have it right. And I don't have any, other than being very meticulous and careful and identifying and safely assessing the tension, I don't have a whole lot of pearls beyond that. How about you, Chai?
Well, I just make sure that I'm, in the subcutaneous, or if I'm not confident of where I am, I'll look for it and protect it. Yeah. Because the last thing you do is, primum non nocere, right?
I know.
So thank you. Hey, Chuck, there was a question for you and you answered it. I saw that you answered it online. But the thing that I wanted to point out, which in your talk, you said something really critical and which I think may have gotten lost. You made a distinction between 2 types of transfers, which Brand had defined. The wrist extensor transfer, which he called the transfer of strength, for which you really need the strong transfer, right? And then he said the transfer, which doesn't have to be so strong, which is the digital extensive transfer for which you can compensate with flexor tenodesis.
Right.
And I think you made that distinction, but I don't know if people got that. It's so critical what you said.
It is. And yeah, I mentioned about the dynamometer. I think
Yes.
you should do it. If you have a patient with a radial nerve palsy, just ask them to hold it and squeeze it, and their wrist will just collapse, and they'll have no grip strength. And as it recovers, say it's, for example, from a humeral shaft fracture, as it recovers, their grip strength will get better. And it's not because their finger flexors are stronger, it's because their wrist is now stable.
So let me ask you this. What do you have opinions about, people propose doing an internal split, just put the prominent teres into ECRL while the radial nerve is recovering. Do you believe in that?
Well, I think I would say it's of historic interest.
Okay.
And it's always brought up, and even in the current textbooks, it's there.
Yes.
And I think aesthetically, it's better.
Yes.
But functionally, it's not better. So, and when we see a patient, for example, with a humeral fracture and who has a radial nerve palsy, we'll give them a wrist splint.
Yes.
And they'll usually toss it, or they'll just wear it when they're now that things are open again at a cocktail party, they may wear it. But to use their hand, they throw it off because they can't actually use their hand unless they can't open their hand to release with it on. So that's a great point. I also, while I'm speaking, I just want to reiterate something about the FDS of the ring finger, which was the transfer originally described. We're taught that about, I remember it as a third, and a third. So a third of patients have an independent FDS, like that, right? About a third of patients don't have an FDS, like me in this hand, right? And about a third of patients have a shared one, which I don't have one. So shared means that they're connected somewhere. And I've had this experience where I've attempted to harvest the FDS here, flex the finger, cut the tendon, and then try to retrieve it in the forearm, and it's flexing the little finger.
Yeah.
And now I've burned a tendon, a motor that's actually motoring 2 digits. Yeah. And so I've switched to the middle finger for my FDS transfers for that reason.
That's an excellent point. And it's not well publicized.
Right.
Yeah.
I agree, Chuck. Yeah.
Okay. I do like the EIP transfer myself, as you mentioned. The FDS transfer is great for combined, and I'm not going to talk about this today because we were not really talking about combined injuries, but combined low, median, and ulnar nerve palsy. The FDS is good because it will give you some adduction as well as a little bit of rotation. It's not great for opposition if you're using the transverse carpal ligament as the pulley, but it's a good option for combined low injuries.
And what Marco said is also true about running short of length when you use the EIP.
Yes. So
Marco, when you want to increase the length, what do you use? You use the palmaris longus, and if they don't have a palmaris, what do you use?
Chai, more and more I've gone to just having allograft available, cadaver graft, and it seems to work. And I'd love your thoughts, but it seems to work as well as palmaris. For EIP, my threshold for palmaris is really low, but if you're doing a different type of transfer, or you need a graft that's more substantial, the palmaris in any particular individual can be quite variable in terms of the length and the size.
Yes.
And if you have a robust bone bank that stores a lot of cadaver tendons, you can just say, okay, I want a 4 millimeter by 20 centimeter graft, boom, and it's right there. And I think that saves some of the consternation and extra incision involved. Not that it's a huge incision to harvest the palmaris.
Do you prefer the semi-T or gracilis or?
I've gone less and less away. Oh yeah, so the cadaver tendons, I think this is a good point. I think the gracilis is a better tendon than the plantaris graft. I mean the allograft. When you get a plantaris graft, and I don't know if you see this in your practice, it almost looks not like a tendon. It almost looks like some synthetic tendon that, or some polyester tarp. It looks like a tarp, like a piece of a tarp that you would use. Whereas the gracilis looks like a real tendon.
Yes, it does.
And I prefer the gracilis, and I can trim down the gracilis if I think it's too bulky.
Right. Great. Chuck, you're doing ulnar nerve, correct?
I am.
All right.
Okay. So, all right. I don't want your brains to explode, but this is a complicated topic. I'll try to simplify it. And so 2 points from today for me. One is the yoke stitch to help to get the laxity out of the recipient. The second is to think about, I'm going to go back for a second, to think about how the FDP works and how we'll call it the lumbricals. Okay, so the FDP actually has 2 insertions. We think about it as one. If you take a fresh frozen cadaver and you make an incision in the form and you pull on the FDP, what happens is it starts to bend at the DIP joint, flexes at the DIP joint, then the PIP joint, and then the MCP joint. And that is not functional. So if you think of the lumbrical as the second insertion of the FDP, okay, when the lumbrical fires, it relaxes the FDP to the tip and it allows your hand to work in a more functional way. So it will initiate MCP flexion. So you can put your hand around a glass, and then once you've gotten your hand around it, then you'll fire your long extensors, your lumbrical will relax. Okay, if you don't have that, you've lost that balance, your fingers will function like this. Okay, that's what happens with ulnar nerve palsy. So what are the causes? We see it with severe cubital tunnel syndrome, compression in Guillen's canal, laceration. It can have it from a lower trunk brachial plexopathy. We see it sometimes in neuromuscular conditions. So again, the posture of the fingers is dependent on the balance of forces, including the flexors, extensors, and intrinsics. And generally, the extensor to flexor moment at the MP joint is greater than the extensor flexor moment at the PIP joint. And the intrinsics are required to balance that. So with intrinsic dysfunction, normal dynamic balance is lost and the extrinsics overpower. So when patients try to extend their fingers, they hyperextend their MP joints. So blocking their MP joints down may allow patients to use their EDC to extend their PIP joints. And that's the Bouvier test. So block them down at the MP joint, ask them to extend their PIP joints. Some patients can do it, some can't. So this is from Smith, some elegant stuff from him, including an article and a video. So loss of integrated MP and IP flexion is due to paralysis of the lumbricals. And normal digital flexion begins at the MP joint. And he makes the illustration about putting your hand around a ball. In a palsy, the IP flexion occurs first, and it actually can push that object away. So high versus low palsy. So clawing is worse with a low palsy because the imbalance is worse because the FDPs are intact with a low palsy. In a high palsy, like a transection above the elbow of the ulnar nerve, it's relatively balanced actually. They don't claw unless the nerve is recovering, then they start clawing. The dorsal sensory branch of the ulnar nerve is intact with a low palsy, as you see there. The likelihood of functional recovery of intrinsics is low in adults. They have clawing, loss of integrated flexion, weak grip, weak pinch, the small finger gets caught. It's important to maintain supple joints. Patients with radial nerve palsy typically do not develop contractures, but patients with ulnar nerve palsy often will, and it'll be their PIP joints. And that burns a bridge if you want to try and restore some balance and they have PIP contractures. It won't work unless the joints are supple, as Chai mentioned. So Bouvier's maneuver, block the MP joints in flexion, and then see whether the patient can extend their EDC, extend their PIPs with their EDC. So if they can, all you need to do is block their MP joints down to prevent that hyperextension. So you can do this lasso procedure, as you see here. Take the FDS and loop it around. The A2 pulley has a little more mechanical advantage than the A1 pulley. And you can loop it around and sew it to itself into the flexor tendon sheath to block hyperextension. If not, that won't work, right? So if you block them down and they can't extend their PIP joints, that kind of lasso is not going to work. So you want to do something to replicate lumbrical function. So this is a simple example, but this will stretch out over time because it's not a dynamic thing. If you took, for example, a free tendon graft and you sewed it from the deep transverse metacarpal ligament volar to the axis of rotation of the MP joint, and then sewed it to the central slip, so that's dorsal to the axis of rotation of the PIP joint, as the patient extends the MP joints passively, since they're now linked, that will extend the PIP joints. So I'm going to show you an example of an FDS anti-claw transfer. And this I would do under, I call it wide awake, but it's not really wide awake. It's IV regional. So the patient's sedated. Here's the clawing. The patient has a little more complex problem. She actually has Charcot-Marie tooth. And so she has good passive, not full, but close to it, as you see on the right, with passive extension of the PIP joint. So that IVs for the IV regional. And so, as I mentioned, having been burned before, this is a transfer to the ring and small. So take the FDS of the middle, distally. You want to take it more distally than the proximal edge of the A1 pulley. So this is in the A2 or just within the A2 pulley. Retrieve it in the forearm, and then make an incision along the radial side of the base of the ring and small fingers, and split the tendon, as you see there, and then pass hemostats or tendon passers through the lumbrical canals. So they're volar to the axis of rotation, the MP joint. And then you find the intrinsic tendon there, so you can see it with the nerve hook around it along the ulnar side. And then pass your tendon motor through the lumbrical canal like that, and you let the tourniquet down. But before you let the tourniquet down, you want to numb up their hand so that they have anesthetic, so they're not having pain. And here it is after the transfer in the operating room. You can see the clawing has been essentially corrected, and the patient has excellent flexion. There are some other transfers. We're going to talk about a couple more. And Marco has a great transfer, ECRB to proximal phalanx ring and small finger, to correct that MP hyperextension when their Bouvier is normal. It gives you modest improvement in grip. Marco.
Oh, thanks, Chuck. That was outstanding, that transfer you just showed. This is a case example of a 34-year-old right-hand dominant male. It was a couple of years after an ulnar nerve repair at the elbow and supercharging, which I think Chuck's going to talk a little bit about later, but doesn't. So a couple things about the Bouvier sign, which is important to know, and that's correction of the extension when the IPs can extend when MPs are held in flexion from that hyperextended MCP position. So that's a critical portion in terms of optimizing or predicting outcome of any tendon transfer for intrinsic return of function. The FDS and FDP were functioning, but somewhat weak. The grip strength you can see and pinch comparable to the other side. So in this case, we opted to move forward with the transfer using the palmaris longus as a graft, next slide, please. And identify the palmaris here. Next slide. Find the ECRB and ECRL dorsally. And you can see that the two tendons, as you can identify them there. So the ECRL is radial, as we all know. Identifying some tunnels to pass through, and the trajectory here. And I learned this from Hill Hastings, this technique, and it's just a wonderful. But there are some critical points. You want to make sure that you pass this freer volar to the intermetacarpal ligaments, and you'd think it would be fairly intuitive, but it's not. So you have to flex the MPs down to really make sure that you're volar. If you do this with the MPs extended, you end up sort of running the risk of coming dorsal, and you can test this before you secure it, but it is an important point to take in. Next slide. And here you can see in the finger the lateral band. Next slide. So once you've got your trajectory and you know where to pass the tendon, the next slide, you can do the tendon graft, as you can see, and you can make a tailed graft like it's demonstrated here, and pass those tendons through those tunnels. You can secure it to the bone through a suture anchor, or you can simply secure it to the lateral band. So either one of those is an option. You can even pass it through with, Hill's original description was to use an incision on the ulnar side of the digit and secure it through and tie it off on the ulnar side of the bone, which is also a reasonable way to treat these. Next slide. And again, you want to sort of get that assessment of the tension and try to optimize the MP flexion and correct that clawing. And interestingly, the tenodesis effect in this case is going to be counterintuitive. You're going to need to flex the wrist to try to get extension of the IP joints, and that's an important take-home point as well. Here's another case example of a patient who had neurofibromatosis, and here we did sort of a whole 9 yards. We did a claw correction for a four-tailed, using a four-tail graft to index through small fingers, and we also went and used EIP to reconstruct an adductor. This is a 46-year-old right-hand dominant male who had a lifetime history of neurofibromatosis. He had excision of nerve sheath tumors in the past, also a neurolysis more proximally, developed progressive clawing over a year's time. And you can see in his hand a couple of things that are not so good, and the fact that he's not very super supple. And you can see his Bouvier sign was abnormal. He did have a fromance. He had significant atrophy, and all four fingers were very, very clawed. Very disabled hand overall. Next slide. So in this case, we wanted to address the clawing, and we also wanted to help with the pinch. Here we used ECRB to the lateral bands and via graft, plantaris and allograft was utilized in this case. Tendon grafts through the lumbrical canal, through volar transverse, again, passing volar to the intermetacarpal ligaments. And the EIP was passed between the index and middle finger metacarpals to get a good pulley, and across to the adductor pollicis with the tendon graft that was used to augment it. And you can see the schematic here, very similar to the last case example. Next slide. Passing the tendons through, and this is after securing and tensioning appropriately. And you can see the position postoperatively. One last thing I will add is it's a little bit easier to correct the tension by repairing sort of proximally sometimes. It depends on, what your what the fingers are and the suppleness of the fingers and the tissue beds. But have it secured distally, and then you can secure it approximately to ultimately create the right tension for getting the fingers in the out of the claw position. Okay, thanks, Chuck.
That was great. So one thing we haven't really discussed is a simple operation, which is fusion. So here for MP instability, and MP fusion is a great example. So that can happen over time as things stretch out due to the instability, imbalance. Marco had mentioned one type of adductoplasty. This is the Smith adductoplasty. So it's an ECRB with a free graft. Again, you need a free graft for these through the second or third intermetacarpal space, and it inserts into the adductor insertion. And it adducts the thumb with wrist flexion, as Marco alluded to. It's a little bit counterintuitive, but it gets tighter as you flex the wrist down. And it's been shown to provide about 50% of normal pinch. So here's a patient who has a complex problem. He's actually got MS, and he had an ulnar neuropathy, and he had an ulnar motor transfer that didn't work. You can see his Frohman sign, the advanced atrophy. And he's a physician, and it's important to ask, what does the patient really want? And if the answer is a normal hand, they will be disappointed. And so we try and chip at these, and there are only so many motors that we can use. And so it's very important to find out what the priorities are. So his priority was pinch. And we use a plantaris here. You can see the ECRB, the incisions made, and also the index finger tends to fall away because of the lack of the first dorsal interosseous. So we're going to do a transfer of the APL. So one slip of the APL harvested, you can see from the radial incision, with a graft again into the first dorsal interosseous tendon insertion on the radial side of the index finger to provide a counter to pinch. As Marco said, sometimes it's easier to do the insertion first, and here you can see pulling on the the tendon attached to the adductor, adducts the thumb, pass it through the second intermetacarpal space in this instance. So it's going across the line of pull of the adductor and then securing it to the ECRB proximally. It's easier. And then the adductor, I'm sorry, first dorsal interosseous was the APL slip with a graft. One common problem that patients complain of is they have trouble putting their hand in their pocket, their small finger gets caught. And that's because the line of pull of the extensor digiti minimi has an ulnar moment. And that's called Wartenberg sign when you can't adduct your little finger. So a simple thing is just buddy taping, but a relatively simple operation is rerouting the EDM. You could do that under local or local with sedation. So detach it from the ulnar side, pass it radially, and that will help to correct that abduction posture of the little finger. You can pass it under the deep transverse metacarpal ligament if you want, and that will help to correct clawing. Could a nerve transfer solve all of these problems? Because these are not great transfers, unlike the radial nerve transfers. So this is the AIN to ulnar motor transfer. There's not a lot of data. It's primarily from Susan McKinnon, and I would say their clawing is improved. They're not going to get independent digital abduction, adduction, but it can work, especially in younger patients. An alternative is what's called a supercharge, as Marco alluded to, which means you sacrifice the AIN and you make an epineuridomy into the motor portion of the ulnar nerve in the forearm. And the thought is that it babysits the motor end plates until the native parent axons regenerate to target muscle. So for example, if you had an ulnar nerve laceration or a really bad ulnar neuropathy at the elbow and a younger patient where there's some potential for recovery. Thanks.
Oh, that was fantastic. Very comprehensive and nicely detailed pictures, which show exactly what we need to worry about. But like Chuck said, you don't want your head to explode from trying to understand ulnar nerve tendon transfers in one session. It's going to need reading over and over and over again before you understand it. Now, in the interest of time, I think since we've covered the basics and all the major nerve transfers, rather than do tendon ruptures, I think we should hear about how to rehab them, because we can do all these fancy transfers, but if we can't rehab them, then I don't think they're going to be much worth. So why don't we go to Shrikant? And Shrikant, tell us about how we rehab these things, and then we'll have some time for discussion.
Sure. So I have prepared a small presentation, so I'll upload my slides.
Go for it.
And then go from there.
And while you're, okay, we got it. Perfect.
Okay. So thank you all for giving an excellent presentation on different transfers. And it's very important for the hand therapist to understand different types of transfers that have been performed for various peripheral neuropathy or peripheral nerve conditions. So we know the purpose of the tendon transfer, so I'll skip this slide. However, it's very important for us to evaluate the hand. We need to look at the muscle function in terms of MRC grade. We have to identify muscular tendinous tightness, if there is any, and how the motion is affected. On top of that, as everyone said, that the joint mobility is the key, because if the joints are not supple, then the transfers will have difficulty or difficult times getting activated. So we prefer to see these patients preoperatively because then we can maximize passive joint mobility. We would like to strengthen the muscles which are to be transferred for a specific purpose. We want to minimize substitution pattern or overaction of the functioning muscles. And of course, these patients will require corrective splinting until we have desired mobility of the joints as well as desired functioning of the muscles that need to be transferred. Let's look at radial nerve palsy. We know what radial nerve palsy entails. We have loss of wrist extensor, finger extensor, thumb extensor. The hand usually becomes very clumsier. And as Dr. Cassidy said, that give them a JMR in their hand, and you'll see that because the wrist is not in an extended position, the muscles, flexor muscles, despite of having a larger muscle bulk, are incapable of generating maximum tension. So in other words, your extensor carpi radialis longus, extensor carpi radialis brevis, as well as extensor carpi ulnaris are the positional muscles of the wrist. Their characteristics is somewhat similar to the sixth muscle of the shoulder. suprainfraspinatus teres minor subscapularis. In other words, that these three muscles that are on the dorsum of the wrist are the positional muscles. They maintain the wrist in an optimum position, maximizing power of the flexors. And if the person has a posterior intraosseous nerve involvement, the only tendon that is intact or only muscle that is intact or functioning is extensor carpi radialis longus. And the patients often show a jerky radial deviation and extension at the level of the wrist. So Dr. Cassidy has gone through the tendon transfers for radial nerve as well as posterior intraosseous nerve palsy. The pronator teres is a common tendon used for wrist extension. One of the wrist flexors is used for finger extension. Brand transfer is favored. Transfer favors flexor carpi radialis, whereas Jones transfer favors flexor carpi ulnaris. And Boyce identified that flexor deterrum superficialis could be used for finger extension, and palmaris longus, especially for thumb extension. So this is Jones transfers. Jones transfers is best for treating cerebral palsy patients when they want to minimize the overaction of the flexor carpi ulnaris, which is pulling the wrist in flex position. So that is harvested and brought in extension so that the person has a greater extension of the wrist. So modified Boyce transfers, Boyce uses flexor deterrum superficialis, connecting it to extensor deterrum communis and extensor DT minimi. And Dr. Cassidy already pointed it out that this transfer is rather difficult to train because of certain reasons. One, it is passing through the narrower intraosseous space. Secondly, the tendon's tendency to adhere to the volar and dorsal structures. And lastly, there is no physiological match between the single flexor deterrum superficialis tendon attempting to power the four fingers on the extensor side. This is the most favored transfer, pronator teres to ECRB, FCR to EDC, and palmaris longus to EPL. So we know every therapist who is working with the transfers, tendon transfers procedure must have a thorough understanding of muscle physiology, hand biomechanics, and of course the principles of tendon transfers, that is amplitude, strength, cross-sectional area, the line of pull, and so on and so forth. So, of course, patients have Pulvertaft weave or side-to-side weave. That means that the weave is quite robust. And of course, it's the surgeon's preference when to start a mobilization. At our facility, we start these patients on post-op therapy. In the second week, patients are given a resting hand splint. We begin with edema control. We'll begin with scar massage once the sutures are removed. And then 2 weeks after, we'll provide these patients with a dynamic splint. That's for the daytime. They'll use a dynamic wrist and MCP joint extension splint. At this stage, we can start retraining the tendon transfers. So wrist flexion finger extension, that is a synergistic motion that we can achieve using this double dynamic splint that allows the wrist flexion finger extension through the dynamic pull and wrist extension and finger flexion. So at night, patients are given a static volar extension splint to prevent extensor lag, if at all that is starting to happen. So we start retraining the hand using the dynamic splinting, as you can see here. Around a 4-week mark, we gradually increase the control. This is, of course, at a later stage, but we'll gradually increase arc of motion permissible at the level of the wrist, as well as at the level of the metacarpophalangeal. Between 2 to 4 weeks onwards, later on, we may use EMG biofeedback for muscle reeducation. Remember that we must remember that it's a different muscle trying to do different action. And many times there may not be a cortical awareness of the patterns of motion that is being performed by the new muscle performing an old action. So we use EMG biofeedback extensively for muscle reeducation. Using the EMG biofeedback definitely helps us retrain the sensory as well as motor cortices, and this helps in regaining or restoring muscle control and muscle function. We begin with active finger and thumb extension, but it's very important for us to understand why we need to activate or initiate active forearm rotation. We know that we often sit with forearm in a pronated position. And if you look at the muscles that are originating from medial epicondyle, They are slack. These are flexor pronator group of muscles. These are slack. And secondly, your volar radial ligament is slack when the forearm is in a pronated position. So it's better to start forearm rotation so that we are minimizing any adaptive shortening of the muscle that is originating from the medial epicondyle. And at the same time, we want to restore the anatomical length of volar radial ligament. It's important that we must begin with a proximal joint range of motion exercises relatively early, because we don't want these patients having any shoulder, secondary shoulder issues at a later stage, because if patients are sitting in a forearm pronated position, arm is in an adducted position, they often will have a tendency to have a primary impingement sign. Between 4 to 6 weeks, we'll continue with EMG biofeedback for muscle re-education until we have attained a desired action. So this is the stage where we can initiate tenodesis exercises. That means alternating between position of the combined wrist flexion, finger extension, and wrist extension and finger flexion. We want this to be well established so that patients have really understood how to activate their transfers for desired motion. That means wrist flexion, finger extension, wrist extension, finger flexion. But as some of these patients' job requirement include that they have to use their wrist in extended position and finger in an extended position, it's important for us to look at their vocation, their avocational activities, and based on that, we can progress them to perform combined wrist and finger extension and flexion. So that means wrist extension, finger extension, wrist flexion, finger flexion. I think that is an important part of post-operative hand therapy. With the posterior intraosseous nerve tendon transfers, we know that the ECRL tendency is quite stronger. So even though the patients have pronator teres transferred for ECRB, they still have stronger ECRL tendency. And in such cases, we need to provide them with the dynamic splint. As you can see right here, the hinge on both the sides makes the wrist move only in one direction. That means that we are getting the central direction of pull, especially at the level of the wrist. And once we have attained that central direction of wrist extension, then we can start discontinuing this dynamic assistment. So dynamic assistmenting is, we use that with EMG biofeedback, helping to centralize wrist extension for FCR muscle re-education. So 6 to 8 weeks, we need to increase the amplitude of tendon motion gradually over time. We must monitor extensor lag. And if there is an extensor lag, we can use EMG triggered electrical stimulation to maximize muscle strength so that we have a desired action at the level of the wrist as well as at the level of the fingers. We continue with tenodesis and combined wrist motion with the finger flexion and extension. And ultrasound can be used, especially if we identify some tendon adhesion. So muscle re-education is very important, as you see that this particular individual is showing remarkable results. We have had remarkable results by using EMG biofeedback, dynamic and dynamic assistment. Now, many times patients have limitation in extending their thumb. So how do we retrain that? It could be as a result of length tension difference. So in order to maximize, or it could be the tendon adhesion. So in order to retrain palmaris longus for thumb extension, we may place the wrist in an ulnarly deviated position in the splint and use EMG triggered electrical stimulation to maximize palmaris longus pull through so that it is effectively causing extension of the IP joint, MPA, as well as CMC joint. And 8 week onwards, you can begin with progressive strengthening. Let's look at median nerve, low median nerve. Of course, the major deficit is loss of thumb opposition. So here, of course, the person is unable to perform 3 components of opposition of the thumb. So let's look at what is the normal mechanism of thumb opposition. So first one is projection. The projection of the metacarpal over trapezium is performed by abductor pollicis brevis. The second phase is adduction. So the transverse fibers of adductor pollicis will cause metacarpal adduction riding over the trapezium. And then the final phase of opposition is rotation and pronation. which is performed by the oblique fibers of adductor muscle, superficial flexor pollicis brevis, and finally the opponent's pollicis. So the tendon transverse that is addressing the opposition of the thumb must be a resultant vector of all these three muscles, three components components are provided by different group of muscles, so that we have nice opposition to index finger or the base of the fifth. For low median nerve palsy, FDS of the fourth finger connecting to abductor pollicis brevis or extensor industris proprius connected to abductor pollicis brevis. These are the two most common choices. Tendon transverse, in other words, should be a resultant vector of all the three muscles, all the muscles that are responsible for thumb opposition. So Huber transfer is best described for hypoplastic thumb or a higher median nerve palsy. FDS4 for APB, I think Dr. Marco described that very well, and EIP to APB, and Dr. Cassidy described that as well. So chemist transverse truly is not an opponent's plasty because, yeah.
If I could ask you to wrap up in 60 seconds, please.
Sure, yeah. So chemist is not an appropriate opponent's plasty because the tendon is passed through the carpal canal, and it is even though it is sutured to abductor pollicis brevis, it truly doesn't perform all the three actions that the opposition pattern of motion is actually. So the transverse tendon does not produce all the three components of thumb opposition. So this is not truly an opponent's plasty. So do you want me to end here?
Yes, please. Thank you.
Okay, thank you.
That was wonderful. We just have a few minutes left, and I want to dedicate them to a little bit of discussion. And
sure.
And I think in the interest of time, there's some questions that we need to have answered from all the faculty. One is, Marco, you said about attaching those slips for ulnar clawing. Do you make a distinction for which digit you attach on which side? Because Hill used to make that distinction, that for the small finger you attach on the radial side and for the index, middle, and ring on the ulnar side. Do you make that distinction at all?
I try to. I don't know that there's a lot of, exact, I mean, I like the way Hill described it. I learned to do it from Hill personally. So I try my best to keep that distinction, but I'm not sure if I can say that it has to be dogma. It has to be,
right.
You know what I mean?
And then the other thing, Chuck, do you have any thoughts about an FDS lasso or like a Zancoli lasso or a volar plate advancement? Do you see a role for them in your practice? And if so, when?
Yeah, I think for technical simplicity, they have some advantages. So for someone who has I would say a general orthopedic practice in an underserved community, that I think those are very good options. I think the downside is it doesn't restore balance, and so they tend to stretch out over time.
Right. So exactly what we talked about, about tailoring it to the patient, and what Srikanth was talking about. Everyone doesn't have to get a complex procedure. Sometimes simple is good, right?
Right.
It's not meant to sound cynical, but. And Srikanth, I was going to ask you, do you notice a difference between children and adults and where neuroplasticity comes into play in terms of how they rehab?
Yes, children tend to learn quite faster. They acquire that patterns of motion very quickly. I've seen that once you show them the patterns of motion, they quickly learn that pattern of motion, and then they're okay. So the time required to train an adult is much longer as compared to training a young child.
And do you notice an age cutoff where you think the child is going to be able to comply with, or just take it on like this? Do you think there's an age?
So I've treated a number of children. I think age 12 and below are much plastic in terms of acquiring the skills quickly as compared to 12 and beyond.
Right.
Because the moment, they say that teenagers have an attitude issues. So I don't know whether that plays a role in them not trying to follow or being told what needs to be done.
And do you tend to use mirror therapy in your rehab protocols at all?
Not much, but I've used EMG biofeedback extensively preoperatively in order for them to understand which muscle is going to transfer, which muscle will be transferred for what action. But action when it is transferred is different than what we are doing, training them preoperatively. We have used EMG triggered electrical stimulation because we know that once they reach certain amount of muscle contraction, then that machine starts to program the electrical stimulation to a certain degree, and the patients have better muscular recovery in terms of strength.
Okay, that's great. We have time for just about maybe one and a half case, but I'll throw it out there to Marco and Chuck. This is a patient of mine who's 11 years, hypoplastic thumb, non-existent thenar eminence, plays the saxophone. And as he's gotten older, the saxophones have become bigger and heavier. And now at this age, he's now qualifying for an adult saxophone, I think. And he just can't do it, and he really wants to play. So what do we do in this situation?
You want to go first?
Okay. Yeah, go ahead, Chuck, please.
So it's interesting that he's presenting at this age.
Yes.
But so it looks like probably he has a stable CMC joint. So that's one of the things that we consider.
Yes.
And so it's a mildly hypoplastic thumb. And
yes.
So they tend to have a first web contracture and instability of their MP joint, as you see there. So part of the treatment, I know we'd like to restore opposition, but we need to get the thumb out of the palm. So we have to do a Z-plasty, some sort of web space deepening procedure, and stabilize the MP joint. And then, Marco showed some great photos of Huber. Huber has the advantage of providing some bulk to the thenar area, so that may be an option as well.
Right, so I toyed with that idea and wondered whether I would get enough power from a Huber for him to be able to use the saxophone. It's
a good question. I agree.
So I chose to go with the FDS. And, this, for those of you who have done this FDS transfer, I used the ring finger, harvesting it like this, and I created a pulley in the pisiform. And you'll see the line of pull is along the pisiform. This is from another case. And as Chuck alluded to, he did need a Z-plasty to open up his web space. And having done that, see, there he is with the abduction. And now he's able to grip his adult saxophone much better. And you can see that his thumb is facing flat, so he can actually hold it almost a true opposition, and not so much an abductorplasty. And I will leave you with this because I think it's joyful.
That's outstanding, Chai.
Yeah, that's great.
The other point is that you can use the graft also to reconstruct the ulnar collateral ligament. It's been described to do both at the same time. And that was fantastic. I know we're running out of time. I have a question for Shakrant. Shakrant, do you have any suggestions regarding adaptive equipment, anything in particular for patients with nerve palsies? Any tips for us?
Yes, I mean there are certain adaptive equipment you can use, especially if in a person has an ulnar claw, and then you have provided them with the tendon transfer, so the grip is somewhat weaker to begin with, so you can enlarge or increase the size of the handles.
And Shrikant, I had an interesting conversation with a patient of mine just yesterday. And they were talking about, so this is a patient who has brachial plexus palsy in addition to paraplegia. And he was looking for adaptive equipment for wheelchairs. How do you deal with those?
You can get, you have that on the steering wheel, you have that cushion, especially the handles.
Yeah.
So for the wheelchairs, you can get the same type of cushioning rim that can be put on the rim which you propel with the hand.
So it makes it wider, you're saying?
It makes it wider so that the gripping is much more easier, right. And then they can have a much easier propulsion when they are wheeling themselves using a wheelchair.
So I think we are just about on time, and I cannot thank each of you enough for doing such a spectacular job with each of your assignments. Thank you to all the audience for hanging out with us. We do have a couple of announcements about forthcoming webinars from AO, and those include flaps, which will be done by Dr. Gupta. And correct me if I'm wrong. Let's see if I can get it off my screen here. Well, it won't let me for some reason. And you'll be receiving the Chris Riley, if you wanted to put up the post attendance questionnaire, this would be a good time to do it. You will be receiving emails about our upcoming webinars in any case, so please keep your eyes open for those. We have 2 webinars in the summer, starting June 10th. We don't have any essential series planned for the rest of the summer. We would like to give you some time off, and we would like to have some time off to have some time with our families. But we will be resuming our series again in the fall. But we do have two freestanding webinars. So thanks very much. Please complete your evaluation, and we are really grateful that you joined us. Good night, everybody.